Welcome back. All right. Thank you, all of you, for showing up to listen to this next installment in the program. I hope that you've had a chance to stretch and move around a little bit. It's a long time to sit in front of a Zoom screen. And good to have you. So, while my goal for this session is to give everyone a high-level view from my perspective of the current status of where we are with clinical translational imaging on a quantitative perspective. And I'm going to be using highlights from today's presentations to make some of my points along the way. As an added benefit, no one will leave today's symposium without getting the big picture of what was covered in the parallel track sessions. And as I'll say this now, I'll say it again at the end. We have been recording all of these sessions, and once they get nicely video formatted and put together, we'll be releasing them on a YouTube channel. And I will send an email to all of you when they're posted live, so you can go back and re-listen and take notes as you'd like. So let's begin today. Hang on, I gotta click to start my screen here. And it's going to let me move. I'm sure it's going to work. There we go. Let's begin with a reminder of the motivation that brought us all back here to this meeting. It's what I opened with for those who were with me at the beginning. And let me just say that for those of you who are living with someone or know someone who's afflicted with a brain disease, or yourself may be suffering in some way, it is really all-encompassing. It isn't hard to feel motivated to try and find solutions that help us to take better care of our brains, our own and those we care about around the world. And so really, it's not a sociology epidemiological meeting. It's really a meeting about what can we do about it. And really, it's about how our work is going to shift a perspective in the world. Right now, brain disease is treated, not prevented. Most resources go into dealing with people once they already are cognitively declining or suffering from a severe depression. We don't catch things early. We don't know how to predict when they're going to happen. And one of the things that's missing are tools and metrics and indicators that help us to know when or who something is going wrong. And it's really an incredibly impactful thing to work on. There's a statistic here that talks about, even if we knew just even 1 year before, even if we could slow down the progression of a dementia that was inexorable, if we could slow it down or delay its onset by a year, saving billions of dollars over time, it's just a place where we could have enormous positive impact. And so there are a lot of things that we know how to do already. There's decent evidence that if you eat more healthy, if you sleep better, if you reduce your stress, if you do meditation, there's all sorts of things that people can do to help increase their overall health and their brain health and give their brain more resilience. And somehow people don't always listen to that, take that message. And we can't always get insurance companies or doctors or people to invest what it takes to act on that knowledge. And sometimes just having a picture, like, here's your brain when it's healthy and slightly going off, can really make a difference in shaping someone's behavior. If you find out that your blood sugar is too high or A1C is too high, you start working harder to control so that you don't end up with the diabetes, right? So we need indicators that tell us early on, things that we can have part of our annual physical exam when we see our doctors that will let us know, is it time to do something? Should we be doing something? And to know if we're at risk. Am I someone who needs to be extra careful about the use of alcohol because maybe even though it's not in my family history, maybe I have a sensitivity that would make me more likely to suffer from an addiction problem. So where are we with that, right? It's a lot of work. We have a lot to do. And I hope that today, a lot of what you learned in the different sessions are showing you how we're making some progress forward while we work towards the goal of having brain imaging indicators that will help us on this way. So in my cute little schematic here, What I hope that today's talks really illustrated is something that I have firmly believed and have been sort of betting the house on, that it's really the interplay between the work done in a sort of a more, we'll call it purely research perspective, where we design experiments and recruit subjects and study them in large cohorts, and do our imaging in that sort of way. And the research that's done and the advanced clinical care that's done with imaging on an everyday basis already, because our imaging technologies are so advanced to allow for that, that the work that's being done in both of these on both of these fronts is critically important. And it's where they meet that a lot of this most important, impactful work will come. And so we focus today, our talks, our sessions were chosen, our speakers were chosen to sort of illustrate that dynamic way that we work from the two sides. And because the research side has a lot more weight to it, my talk is going to spend a little more time giving you some more sort of the a little technically stuff on the clinical sides, showing off a few of the dark sides that may not have lifted up when we were showing off what cool things you could do with the data that was coming from this side of the abyss as we build our bridge. I will point out also that we spent a lot of our time today talking about MRI and TMS, about EEG, and not many of the other modalities that actually sometimes are used and often are used in this space. So we could have many more symposia, maybe we will. We'll see how things go. That would help us to use even more of those, look at in more ways at how different kinds of neuroimaging is advancing us for indicators of brain health. But I chose to focus in this space because these are really the workhorse image acquisitions in clinical practice now. MRI and EEG. PET is specialized for just certain disorders, but MRI is much more ubiquitous right now. And I'm hoping that, because of these various talks, all of you have a truer experience of that interplay. And I hope you have a better appreciation for what kind of data the clinicians can have access to today, and what they can order, what they can do with the data that they've gathered. One of the things that we did not have a chance to talk about, I'm going to just make a quick commercial for a textbook that's about to come out, is the whole domain of clinical informatics and its burgeoning, subdiscipline of mental and behavioral health informatics, which is our ability to really gain very detailed information robustly from our electronic healthcare records that would inform this kind of research, how our brains are functioning and doing as reported or gathered by clinicians caring for patients who have different kinds of brain disorders or who don't. And so I'm going to just give you my commercial that when this book comes out, there's a chapter in there that I wrote with my junior colleague, Nicole Benson, where we really focused on this interface between the medical imaging data that's available and behavioral and mental health informatics. So illuminating where there are good resources, what references to use to sort of understand and move yourself forward in that field. And so someone who's interested in doing this kind of work may find that very helpful. So just want to reiterate one of the most important points raised across many of the talks, which is how important it is to have a lot of data, much data. And the more data that we have, and the more it actually reflects the human population that we're seeking to help and support, the better. And so one of the inherent limitations with research side work is that there's very strict, criteria for how you get into the study. One of the real interesting and important and impactful parts of using the clinical images that were gathered for caring for patients and then using them secondarily for research is that there's a lot of data, and it's real world data, and it's fairly unique. It's collected on populations that we don't always easily gather in research studies. And so, for example, if you are thinking about yourself wanting to develop one of those machine learning algorithms and you think you can do it better than anyone, and you have this great idea for how you're going to do it, but you need a lot of data, if you can find a partnership with someone who has, to create a safe enclave of data extracted from a hospital PACS, you can readily consider the idea of how you could gather 200,000 brain MRIs, extract those hippocampal volumes and temporal lobe cortices, and build your tools for screening for evidence of cognitive decline. The advantage you'll have is that you won't hit up against that shortcoming that Eugenio and others were bringing up, which is that your tool will be optimized on real data as opposed to this very better quality research data. And so you'll already be in a position to say that this work that you're doing is immediately clinical translatable. There are a lot of differences comparing and contrasting what it means to work with data that was collected on in a specific research protocol versus what you aggregate and mine from a clinical PACS system. You heard when people were describing their data sets in today's lectures, typically, and you're familiar, many of you may be very familiar with things like the ADNI and ABCD, there's a very standardized, very carefully selected acquisition protocol for how the data is gathered. Their quality is chosen to be the highest possible. That will, if it's multi-site data, it's to the highest common denominator. Some people call it the lowest common denominator. And the patients, or the subjects that are in your study, carefully screened, meet all your inclusion, exclusion criteria. And specifically, one of the things that I really am always kind of scratching my head about is that we very rarely study patients who are comorbid. That means they have more than one disorder. If you want to study depression, then you exclude everybody who has other, you often exclude them if they have major medical problems, or they also have anxiety or a substance abuse problem. And in the real world, people are not so uniquely bothered by things. More typically, most of us are a mosaic of stuff that's working and not working. And so these carefully screened cohorts do and don't really reflect the normal human variation. And finally, when you're working with research data, you also get a lot of other pieces of information about that, about your subjects. You have a lot of quantitative information, and it's collected in a very standardized format. Your case report forms, or your quantitative assessments, your rating scales, or whatever those are, your time, how many seconds for pressing a button. On the other side of the coin, our clinical data is collected not because of a research protocol with research dollars paying to acquire it, but it's collected with insurance or the patient's own money paying for it, and it's customized for answering a clinical question. It's customized for what that patient needs to address their clinical issue. And in that case, for someone, for instance, if they come in and even though they may be having a brain scan, it may be to rule out an acute stroke, in which case the very fastest scan possible will be done, because that person needs to be swept into an intervention suite in order to save their brain and preserve their function, and not try to get the prettiest pictures for your research. Whereas if the person has an epilepsy, an intractable epilepsy, and you're struggling to find that tiny cortical dysplasia, this abnormality in a little cluster of cells somewhere deep in a sulcus of the cortex, you're going to get the highest resolution, most beautiful scans you possibly can. And very rarely is a scan done clinically if the person is perfectly healthy, if they have nothing wrong with their brain, because those images need an insurance or self-pay reason to be collected. And so there has to be a really justified a reason, at least much more so now, as we're in a time of a little bit less largesse, as we were in neuroimaging. Back in the day, in the old days, when I was in kind of your guys' starting days of medical school, and MRI had just been invented. I remember sitting in the radiology dark room looking at a chest x-ray, and the resident running down the hall waving a film of his first brain MRI that had just ever been printed on a sheet of x-ray kind of paper, because they didn't even have workstations to look at the scans. And they were so excited because with the brain MRI, you could see the details of the brain so beautifully. And so this is really, a lifetime's worth of time where we are now finally at a point where the quantitative metrics that we're pulling out of these scans are useful in a way that could barely have been imagined back, even in my lifespan. Okay, that was a little digression, I apologize. So rarely normal, we rarely see these normal scans, but the point I was trying to make on that digression was that when MRI was first introduced and starting to become more available, the threshold for an approval for one was a little bit lower, and we collected a lot more data because clinicians were still learning what we could or couldn't learn from looking at the MRI data. And there was still so much that everybody was starting to understand about what you could understand from an MRI and what you couldn't. And so there are now more strict limitations. If you have chronic back pain, it's not always the first line to go get an MRI of your spine, for example, because those studies are very inconclusive often. And so, okay, so my point is that there's a lot of data out there, a lot of clinical data, but it's messy and complex, and it takes a lot of data curation to get it. And I have a slide, I'll talk you through a little bit more details about it. And so it's really important, if you're going to use the data from a clinical repository, whether it's EEG or MRI or CT or PET, that you work very closely with a colleague who might be the neuroradiologist or the epileptologist, or whoever it is, to understand at their center where this data is coming from, how consistently a data protocol has been, these acquisition protocols are used. Are they standardized? How do they standardize? How often are they updated? How frequently are they customized? Which of the sequences or protocols that contain multiple different sequences, different contrast in MRI like diffusion and T1, T2, susceptibility weighted. How consistent are those acquisitions, so that you'll have a feeling for what kind of data, an intuition for what kind of data will be available for the study you want to do. So we heard towards the exciting frontiers that were highlighted in the talks that we shared today. One of the things that was shared was some really visionary work that Nalini Singh is doing with some of our faculty colleagues, where her work is aiming to be something that's able to get rid of some of the noise and some of the corruption in the imaging data, and is a kind of an approach that would be best incorporated by the scan manufacturers, because it requires working with the case-based data, the frequency data that comes at the time that the scan is acquired. And so most clinical PACS systems, for example, don't save that case-based data. It's used to generate the images through a Fourier transform. The images are archived, but case-based takes up a lot more computer hard disk space, and for financial and logistical reasons, it's typically not saved at most hospital systems. And so before you get too excited about trying her thing out, make sure that you have a data set where you can get case-based to work with, or talk to your friendly colleagues at the imaging center where you collaborate to be able to try this out. But her work is incredibly important because she's working with a team and there are many around the world where they're adding these kinds of improvements to the acquisition, with the goal in mind that the data that's in the PACS will be always and continue to get higher resolution, better quality, less artifacts. And there's, that we could whole symposiums on how the acquisitions are improving across each, one for each modality, to get better and better quality data. And for that impacts positively on the research side, but also very importantly on the clinical side. Eugenio, in that same session, shared with us an approach that actually is available to collaborate with him to take it from research to even more robust research use, that lets you take the data that is available in your PACS, and if it is these sort of lower resolution, thicker slice MRI scans, be able to use his machine learning algorithm and develop through his clever idea of generating these synthetic training data sets that use the information from each of the different resolutions of a scan to create synthetic high resolution scans that can be run through our more advanced image processing pipelines. And so a scan that might not have been available to use for research because it wasn't a sufficient resolution. Say if you wanted to use FreeSurfer, for example, you wouldn't have been able to. But after his magic, a previously unusable data scan may become usable. And so that's a real exciting advance, and one that I'm cheering and hoping to help him with. And what else? So Dr. Wu in his session shared with you the work that he and I have been doing together with our colleague Ellen Grant and a team of really wonderful scientists. That here is kind of it's my in some language we call it driving biological project. Here's my exemplar of, if you have a fabulous neuroradiologist who actually knows about good quality imaging data in your packs and who has a vision for what you can do with it, this is the kind of project that it's worth doing with your clinician colleagues, okay? So Ellen was somebody I bumped into as I was running around trying to find the perfect study to validate the work that I just wanted to do to make it easier to pull that PACS data out of our hospital systems. And she and I had this conversation in the hallway for about 30 minutes. It turned into a specific aims page. It turned into a grant, and then another and another. And the idea that she had, literally the vision of what she was hoping to get to, was just published. I think it's 15 years. It was just published in Radiology last month, which is these are figures from that paper. Essentially, what she said to me was that the way she had set up our scan protocols at our hospitals, and now this is, she has actually set up the protocols across several of the teaching academic healthcare centers that do pediatric brain imaging. She has set that protocol up so that we do get T1s, T2s, but importantly, she put in, starting in about 2008, these diffusion weighted scans with a very consistent B0 values and very consistent directions and a very consistent algorithm for generating ADC maps, so that when we went to pull the data out, we would be able to find a cohort of information that was useful. And importantly, what she wanted to be able to do was to create both a teaching tool and a radiology support tools that would allow her to really quantitatively use that ADC information to understand in exquisite detail, literally every voxel counts in a baby's brain, what was going on, because the ADC values, unlike in adults, are quite stable. ADC values are relatively stable in adults, but certainly in very early childhood and babyhood, as you saw from Yang Ming's graphs, that those values change very rapidly. And so for a clinician to understand whether there was pathology in a particular place in the brain, they had to have an intuitive understanding of what the ADC value should be at each different place in the brain, and how and what it should be at that particular moment in life. And that moment in life was impacted by literally how many weeks gestation they were when they were born, or if they were a preemie, or if they were a full-term baby, and all those things impacted what those numbers should be. And so the work that we did together allowed us to build some virtual atlases, some normative information with means and standard deviations that allowed us to understand what normal looked like. And importantly, one of the things she said that was just so cool, she's like, the brain, the ADC values, we see that maturation, it moves in like a wave. It starts earliest at the back of the brain in the occipital lobe, and it moves forward. And here is this lovely illustration of exactly what she had to say in that hallway conversation. And so it's there, and she knew it. And it was really important for us to do this work so that this is now information that's in the hands of every radiologist who is working to understand this data, and they can use this to help them to do their work. So here's the sort of schematic, the numbers of what I just talked you through. So we have a tool at our hospital. It's called the RPDR, stands for Research Patient Data Registry. It's our giant query front end that allows us to access a database of research, basically our clinical informatics research front end. And we can use that to identify cohorts of interest. this tool is really unique at our institution, but if you have an I2B2 informatics network, you might be able to do this where you are, but talk to me afterwards and we'll figure out how to help you. But we use a little software tool that lets us access the scans and do the quality control, and then confirm in our medical records which subjects are healthy, and then once we have clear data that we know is normal, we can build those atlases and start building our tools. But importantly, this early part of the workflow incorporates our IRB regulations and our human subjects protections. And so that infrastructure has to be in place, and that's one of the key ingredients. So we also heard, for that study, which was done with this ADC data, because there was so much consistency in how the data was collected, issues of harmonization were a little less important, but not unimportant. And I will let Yang-Ming answer the question himself about the steps he took for the harmonization, but there was a beautiful talk by Supela who described many different ways and approaches that you could take for harmonizing data if the data sets that you're working with are not as nicely harmonized as at the beginning, or you want to take them even to the next level. And the better you are able to harmonize that diffusion data, the more able you are to use these visualization tools and to use the more advanced image processing like tractography to look for subtle findings and more specific abnormalities in a patient or in differences in cohorts. And we, again, another topic there was just no time to delve into in this symposium was but we gave you a teaser for, was the lovely presentation by Lorraine that lets you get a feel for the more advanced visualization software tools that are becoming available. Find a partner to work with you on that, because when you have these huge machine learning studies, having that kind of intuition about what drove what you want to looking at, what drove a finding, what does it mean? It really helps, as we humans are quite visually driven. It helps us to be able to know and understand and interact with our data in that robust way. Inspirational always work from Dr. Whitfield Gabrielli, who talked about and showed us how close we are to having some predictive types of findings from functional MRI data, both task and from resting connectivity. And her work spans so much more than we were able to see together today. And so I encourage you, if you found her work interesting, which I'm sure you did, that you look into the other things that she has worked on as well. At her lab, we could do a whole symposium on the various projects just going on under her, that she's collaborating with or supporting, that it spans the full range of neuropsychiatry. We saw from the sort of clinical translation side, we saw some beautiful work that Sean Siddiqui shared with us about how using TMS and deep brain stimulation, we're able to learn more and more about neural networks and their causative features for where brain symptoms such as depression and anxiety, addiction, what might be substrates for those, and how we can use our tools like TMS to help our patients to recover. But one of the key teaching points from all the work that he pulls together is these different methods all bring us towards, we have one brain, and being able to use research tools that span these different approaches and methodologies, and where we find convergence is really important, as well as where we find divergence. And so there's lots of lessons to learn there, and huge way that we're moving across that bridge from that kind of work. Definitely was doing a good job recruiting you to work with him, and I endorse that. All of these labs, I endorse that. We had a sampling of clinical data pulled from from the sleep labs. Dr. Hauchi-san gave a beautiful presentation on another way of generating an index of brain age, this time extracted from sleep EEG. One of the key learning lessons from his talk, which is super important, is that this brain imaging data is noisy, but it's important that we learn ways to generate cleaner and cleaner data, decrease the variance, and increase our sensitivity so that we have measures that allow us to robustly find indicators that really help us understand about brain health. And some of the exciting work that is happening in this group is at the McCants Center, where we really are starting to investigate this metric as well, a way, because it can be done at home safely and easily and less expensively, and can be monitored routinely and over time. This is something that really has great promise for giving us some of those brain indicators that could go into clinical translation much more easily and more broadly with more access across more populations. I am running out of time, so I'm just going to call your attention to, there is just so much more. I will lift up from the bottom line of Dr. Eichhoff's keynote, which was just fabulous, that there's just so much more. We could run symposiums on every corner of this. And I left blank, I put myself a little blank spot here because he didn't give me a box for it. There's one domain that I just really want to let everyone know that we didn't deal with, but is really important. And you can look up Simon's own writings on this, but many others, whole conferences on the ethics of what it means to have these brain indicators, brain imaging indicators, so many different domains where there are important ethical considerations, whether it's access to these technologies, across different disparities that keep people from having access, whether it's bias that's introduced because the sample that's used to train a tool doesn't really take a whole population into consideration, and so will fail when you test it on a person who doesn't match the demographic about what it was trained on, whether it's the impact of a finding on someone's insurance, just so many ethical questions. And the good news is a lot of smart, good people are paying attention, as all of you should. And for everything that you work on, it is important to take those things into consideration and to be mindful and to be educated about them. And so my lack of attention in this symposium was not to undermine its importance. In fact, I assert that everyone should be an expert in this domain for the work that they do if they're going to be in this field. But it's more out of respect to the fact that you can't do it quickly. It deserves its own attention. And so there's great resources for that out there. I want to conclude with, my buttons will work, yes. But again, just I love this picture that Yang Ming put together that helps us to understand, it's sort of I was hoping to summarize even more. So many things to do with the data, so many ways to bring these indicators to life in ways that help us, and still so much work left to be done. We're working on a review paper. When it comes out, you will see this in more detail. And so now it's just time to move to thanks. A lot of thanks. Thanks to the planning committee, all my faculty, colleagues who helped me to shape what happened today, to choose the speakers, to choose the topics, to sort of focus in the way that we did. I hope that they know how grateful I am for their help. I want to also thank the speakers who did such a fabulous job preparing and responding to your questions when you were able to share them. Really proud of my students, stepped up in a great way. So fun to see, the dynamics that come up when you have more senior and more junior people discussing and debating on some of these issues in the field. I want to also acknowledge the NTP, the training program, and I appreciate the support we get from NIBIB for this long-running program, and my co-director, Bruce Rosen, without which so much of this would not ever be. And I want to end by thanking, in particular, Henry McCants, the founder, the visionary, who worked with our co-founding team to establish the McCants Center for Brain Health, and really inspired a lot of the direction that today's symposium was trained towards. So much more to do. Join us along the way. And I will reiterate now at the end, in case somebody missed me saying it at the beginning, we have been recording these sessions, and once they're nicely fixed up, they'll be up on a YouTube channel that you will be able to find at the McCants Center for Brain Health under our events tab. I look forward to seeing some of you in the social rooms. Please join us in the next session. That is a purely social place where you can network. We still have like 80 of you here, so find friends, meet friends, Some of our faculty and mentors will be there schmoozing around. Schmooze, that's a Yiddish word meaning hanging around, talking. It's what, if we were in person, it's what we would be doing as the lecture ended and was spilling out and you were all chatting in the corners with each other to shake hands and to, oh God, do you remember when we could shake hands? Oh, anyway, so my last slide is, oh yes, so you have to go back to your website to that social break, click on your view sessions and you will be there. I want to thank our production staff for making such a smooth, wonderful event for us. And I want to wish all of you a very happy, healing, no more COVID ever in the years to come, with robust steps forward and our ability to understand and protect brains. So happy New Year. And I will see you in the little rooms.